Dr. Jeffrey, I'll now ask you to introduce the Minister of Health, the Honorable Paul Merriman, and the Minister of Mental Health and Addictions, Seniors and Rural and Remote Health, the Honorable Everett Hindley.
Thank you, Kishore. So now it's my pleasure to introduce our two ministers from the government who are here with us today. Minister of Health, Paul Merriman. He was first elected to the Saskatchewan Legislature in 2011. Minister Merriman was re-elected in 2016. He has served as Minister of Social Services, Government House Leader, Deputy Government House Leader, and Government Whip. On November 9th, 2020, Premier Scott Moe appointed him as Minister of Health. Minister of Mental Health and Addictions, Seniors, and Remote and Rural Health, Everett Hindley. Minister Hindley was first elected as an MLA for Swift Current in 2018. He was re-elected in the 2020 provincial election. Upon the Saskatchewan Party's election to government in 2007, Minister Hindley served as the executive assistant to the Premier. On November 9th, 2020, Premier Scott Moe appointed him Minister of Mental Health and Addictions, Seniors, and Rural and Remote Health. Welcome, ministers, to the Representative Assembly.
Tracy's here. Oh, I get two chairs. Are we good? You can hear me? Okay, perfect. Thank you very much, Dr. Jeffrey, for not only the introduction, but also your guidance and your friendship over the last year. Very much appreciated. Thank you for your service to the SMA. And I'll get right into my marks. And thank you very much for everybody coming out today. I see some faces that I recognize in the crowd and some new ones out there. So thank you very much for spending your Friday with us. I'm pleased to be here today along with Minister Hindley, the Minister of Rural and Remote Health, on behalf of Premier Scott Moe and the Government of Saskatchewan. I want to say again, thank you to Bonnie and Dr. Jeffrey and the SMA board for inviting us, and thank you for those that are attending here today. Before we begin the Q&A session, I'd like to talk about family physician compensation and physician recruitment and retention topics that are a high priority for everybody here. First off, I'd like to recognize the work of the Primary Care Compensation Working Group in bringing forward a set of recommendations for a new family physician compensation model in Saskatchewan. I know that competitive compensation is a key to attracting and retaining doctors here in Saskatchewan. That's why I'm pleased to confirm that our government supports moving forward with the development of a new blended capitation model in Saskatchewan. We really got to figure out a better name for that. As the Minister of Health, in collaboration with the SMH, begins working to formulate the Made in Saskatchewan model. Our priorities will be to ensure that we are improving patient access to care, enhancing team-based care for patients and providers, and creating an environment that attracts and retains family physicians for our province. While work for this is underway in the coming weeks, I understand that fully implementing a robust blended capitation model is a long-term position. In the meantime, we will continue to work with the SMA to identify incremental improvements that can be made to improve patient access to primary care and attract and retain physicians in the short, long, and medium term. To that point, in March, Dr. Jeffrey and I announced an agreement in principle that enhances physician compensation and is designed to improve patient access to family physicians. I'm pleased to confirm that we have since finalized the details of this compensation enhancement. Effective May 1st, 2023, increased funding is now available to urgent care clinics offering after-hours and urgent care service to improve access for patients. In addition, all community-based fee-for-service family physicians will be eligible to receive an additional payment per visit service. These changes will be aimed at supporting community-based family physicians to extend their office hours if they are available, and I understand that further programs have been distributed to you by the SMA. I'd like to briefly touch on our government's other investments aimed at addressing the recruitment and retention of physicians. In this year's provincial budget, we are investing a record $6.9 billion in healthcare. This is the largest healthcare budget in Saskatchewan's history. Nearly $100 million in funding in this year's budget will continue to support our 4-point Health Human Resource Action Plan, which will accelerate and enhance the efforts to recruit, train, incentivize, and retain doctors, nurses, and other priority healthcare workers within our healthcare system. Our government understands how important it is to train doctors here in Saskatchewan. That's why we continue to support the expansion of our medical residency seat from 60 in 2007 to 128 seats today, including 8 new seats that were added to the College of Medicine in this year's budget. In March, Minister Hindley and I joined with the University of Saskatchewan College of Medicine to celebrate the expansion of the undergrad medical doctor program in Regina. This expansion will allow our medical students to be able to complete their full 4-year medical degree in Regina. Minister Hindley will have more to say about the additional targeted investments that we are making to support recruitment and retention of physicians in rural and northern communities. These are some of the steps that we are taking to meet the needs of patients and physicians. We know that there is a lot more work to do. Minister Hindley and I very much appreciate the continued collaboration with the SMA, its leadership, as we work to find the best solutions to improve patient and increase supports for our physicians. I want to thank you for the opportunity to speak here today. I look forward to hearing your thoughts in the Q&A. I want to also thank my officials. Tracy Smith is sitting here beside me, our deputy minister. And we have a bunch of ministry officials here, and I think Andrew will. If you guys could just stand up and be recognized. Looking at you, Rebecca. These are the amazing people that work with Minister Hindley and myself behind the scenes that I'm sure some of you recognize that help support the initiatives and action what we're trying to do here in Saskatchewan. With that, I'll turn it over to Minister Hindley.
Great. Thanks, Paul, and good morning, everyone. It's great to be here once again today at the SMA RA. As Minister Merriman mentioned, this year's provincial budget makes some fairly significant investments into healthcare to support the programs and services right across our province for all of our residents and to help strengthen and bolster and enhance our healthcare workforce. As the Minister of Rural and Remote Health, I'd like to highlight a few of the initiatives that focus on recruiting and retaining physicians to our rural and remote communities across Saskatchewan. So, for example, we have continued to support the expansion of the Saskatchewan International Physician Assessment Program, the SIPA program, from 36 to 45 seats annually, which of course will mean that more physicians will be able to practice in Saskatchewan communities with the vast majority of our SIPA graduates practicing in rural and remote areas of our province. We've also taken steps to retain the new doctors who have been recruited to our rural communities. That includes the Rural Physician Incentive Program, which, as you likely heard earlier this spring, has been increased to $200,000 over 5 years, more than 4 times the amount that was previously offered. Eligibility for that particular incentive is also expanding, so beyond just the new graduates, and will now include physicians practicing in rural communities who are assessed through SIPA. To incentivize retention, the length of the program is increasing from 4 to 5 years. This will provide some stability, and over that time, we're hopeful that the physician and their families may decide to put down some roots in communities and opt to stay there permanently, well beyond the length of that particular incentive program, and that's the goal and the target of why we're doing what we're doing around that particular initiative. In addition, we are establishing a new independent agency dedicated to the recruitment and retention of health professionals. That includes family physicians and other specialists in healthcare. The Saskatchewan Healthcare Recruitment Agency will help attract the human resources required with a focus on addressing the challenges, not just in our urban centres, but also in our rural and remote areas as well. The initial membership of the board includes the Deputy Minister of Health, Tracy Smith, and the SHA CEO, Andrew Will. And yesterday, you may have heard that we announced that Aaron Brady has taken on the role as the CEO of the organization starting on May 23rd. And Aaron's tasks will be building the organization and developing a strategic plan. By focusing on key recruitment and retention practices, we're able to attract more physicians to practice in the communities where they're needed most, and to help, most importantly, support all of you that are here in this room here today and your colleagues right across this province. We as a government will continue to promote Saskatchewan as a place where you can have a successful and a rewarding career in healthcare and be part of strong and supportive communities right across this province, regardless of where you choose to live, work, and raise a family. And with that, I'd just like to thank you again for giving us the opportunity to speak to you and with you today. And Minister Merriman and I are looking forward to your questions here this morning. So thank you.
Ministers, thank you. The ministers have graciously allowed time to receive questions from RA delegates. Please remember, once you're invited to speak, please speak loudly and clearly, state your name, and be brief with your questions so as to allow all interested delegates the opportunity to ask a question. You will have up to 2 minutes to ask your question, and please refer to the timer on the monitors. Please also remember that non-RA delegates may pose questions, and the non-RA delegate microphone is over here. It's on the right side as you are facing the stage. Let me start at microphone number 1.
Hi, Donna Lettingham, Lab Medicine, Regina delegate. I'd like to thank the ministers for their time today and also for their really hard work in supporting healthcare close to home in Saskatchewan and the foundational primary care initiatives. I'd like to ask today about some close-to-home lab testing initiatives that we placed before the ministry, and just wondering if they might be spoken to, specifically syphilis. I think our public health team our lab public health team did a good job of distributing COVID testing, and we're trying to do the same for syphilis. And it is, when it receives attention in Australia, one feels a little uncomfortable that we're maybe could be doing better for our patients. We placed together the distributed lab testing and point of care testing programs before the ministry, and are just wondering if you could update us on the funding, please, ministers or your colleagues on the bureaucratic side of the House. So thank you.
Thank you very much for the question. We do know that there has been some increase in syphilis as well as some other ailments. I'm just trying to think of the proposal you're specifically speaking about. I haven't seen that proposal yet. I don't know if it's with the SHA or if it's with the ministry. I'm just looking. Rebecca? Yeah. Okay. Do we have any comments on that, or can?
Rebecca, yeah, I can say we do have the proposal, and we will be working with the SMA on that. Some decisions are still forthcoming, so as soon as we're able to provide some more details, we can. But I can just sort of reassure the group that we do know that this is an issue. It is a priority, and it is something that we need to take some actions to be able to address it. So thank you.
What I'll get, Dawn, if it's okay, I'll get Rebecca to connect with you and just follow up with you directly on some stuff, and then Minister Hindley and I can get some updated information at our next briefing on it.
Great, thank you.
Thank you. Microphone 2, please.
Good morning, ministers. I'm Crystal Litwin. I'm a rural family doc from Wynyard. And I'd very much like to thank you for the announcement today about the blended capitation model, because I think that gives a lot of family physicians like myself that practice comprehensive family medicine hope to continue doing what we're doing, maybe not retire as soon as we were thinking, maybe bring some people back that have left that sort of practice in family medicine to do hospitalist or ER work or other things, so that's great. My topic today is about the incentive program for human health resources in rural centers. So as you are aware, we often struggle with nursing, lab, CLXT, and it's leading to disruptions in our abilities to provide services. And although your incentive is a good plan, I would like you to review it and maybe offer some flexibility. So for instance, right now you have to have the ability to give this incentive to full-time permanent positions. A lot of communities like our community, CLXTs, we have a temporary full-time mat leave that's been open. We have a part-time position that's been unfilled for a year now. So as a result, we are having to close our emergency half the time because we only have 1.2 CLXTs working for us. So I would like you to expand that program to offer it to maybe part-time or temporary positions so that we can actually fill the positions. We can't compete with the incentives being offered to other facilities.
Thanks, Crystal, for the comments. And just I'd say a couple of things on that. One, we're trying to build capacity, and you're right, because when we don't have those positions filled, it's difficult, if not impossible, for you to do what you do as a family physician. So we're doing everything we can to make sure that we're filling these positions. You'll recall that we've made some enhancements and put some funding towards creating more permanent full-time positions in a number of communities across the province. And we started with that in the action plan we launched in September, committed more dollars to create more permanent full-time positions in this spring's budget. Now, that doesn't address all the gaps that we have out there. What I would say on the incentive program is, and I'm glad you raised the question, we've got officials here in the room, we've committed to, since we announced that program back in September, saying that that's not the be-all and the end-all. We recognize that there's going to be some tweaks that will need to be made along the way. We've done some of that already and made some additions. For example, adding communities that perhaps didn't qualify initially in our first list in terms of being applicable for the incentive program. So we've added some communities in there. But this is good feedback, I think, because we want to make sure, just as we're discussing here today, that we have a healthcare system that's flexible and adaptable to the changing needs of our province. Same goes for us as government in these programs that we develop and design. So we can definitely take that back to our officials, and as we continue to build this program out, look at making necessary changes to it. We'll take a close look at this because we do want to make sure that we're trying to fill those gaps. I'm aware of the shortages that you have in your community. Your MLA has raised those with me directly, and we've had an opportunity to talk about some of the solutions there, working with Andrew and the folks at the SHA to try to do everything we can to fill those gaps. But appreciate that feedback, and we'll take that back to look at some potential changes to the program.
I'm going to come to microphone 1, but I just want you to know if you're at microphone 3, I see you, but I am going to give priority to the delegates, so hang in there. Microphone 1, please.
Thank you. Excuse me, Al Beggs. I'm the section rep for orthopedic surgery in the province. So thanks for your time. The question today is regarding the proposal or plan to migrate predominantly hip and knee patients to Alberta for more urgent access to arthroplasty. As of our meeting last night, there isn't a Saskatchewan-based surgeon who has received any notification of any kind with respect to a patient having been migrated to Alberta for arthroplasty. And as we as a section are unanimous in not providing support to that program, that's good if the patients have not in fact gone to Alberta. If in fact there have been Saskatchewan patients migrated to Alberta, what we'd like to ask is that there's a robust and transparent communication back and forth between the operative surgeon in Alberta and the initial consenting surgeon in Saskatchewan, because the very real possibility is that the Saskatchewan surgeons who have not operated on these patients are going to be required to provide urgent or emergent care in the unfortunate event of a complication, etc. We cannot access their imaging in Alberta, we cannot access lab values, and we cannot access operative reports, and all of that is going to be essential for the safety of these patients who are being sent to Alberta for care that they could and should obtain in Saskatchewan.
Yeah. Thanks very much for the question. First off, I just want to clarify, this is a temporary solution until we can get our surgical backlog. This isn't something that we're looking at ongoing with knees and hips in Alberta. I guess my question, Absolutely, we should have the communication back and forth. Is it Alberta not allowing us access to their information? Is it a bureaucratical between the two provinces? Because I know if somebody goes outside and gets a surgery outside the province for whatever their reason is, there might not be that follow-up. I'll have to check with the contract, but as far as I understand, the information should flow back to Saskatchewan as we are paying for that service. It should flow back to us. From your perspective, is it bureaucracy or is it it's just not happening?
Well, there has been no information to any surgeon, any orthopedic arthroplasty surgeon in Saskatchewan. Presumably that is the pool from which these patients have been drawn. And if I don't send a note back to my referring family physicians, they should and would be rightfully upset by that. So I'm not sure where the breakdown lies, whether it's an e-health problem or the Alberta equivalent of that. But regardless, the communication has not occurred, and if a patient has been operated on in Alberta thus far in this program, then clearly there needs to be communication back to us so that we can manage any potential and unfortunate complications that may arise.
Yeah, to my knowledge, I don't know if anybody has actually been sent there through this program. We haven't sent anybody out there yet. Anybody that's gone there has gone of their own volition and got the surgery and paid for it themselves. We haven't sent anybody, but we'll make sure before we do send anybody that there is that loop back to the family physician as well as the surgeon, so everybody is in the loop as to what was done and potential follow-up. There is some, if there's some bureaucratical problems with that, then we'll deal with that at our level, but we want to make sure that all the information is flowing with the patient.
Thank you.
Phone 2, please.
Great, thank you. I also want to thank the ministers for coming today and
Introduce yourself to the room
I'm sorry,
and say
yeah.
who you
So,
represent.
I'm Ben Leese. I'm the section chair of internal medicine, which covers over 200 specialists across the province. But I wanted to thank you for coming today and giving us face time because we appreciate the opportunity to tell you about what we care about. The family care and primary care crisis is what I'm here to just outline or highlight. It affects us all, not just family physicians, and 20% of patients don't have a family doctor right now in Saskatchewan. It's making specialist care very difficult as well. Patients are presenting with advanced disease because they haven't seen a family doctor in years. They've delayed discharges from hospital and contribute to overcrowding because multidisciplinary outpatient care isn't possible. They also come in with severe complications of chronic disease, which could have been managed, with upstream follow-up. So it's a big problem. It's great that we're investing in urgent care. I think that that's the most, urgent need, pun intended. But the issue with that is it's a Band-Aid, and there's upstream solutions that are required. And at no point in either of your addresses have you really made it clear that there's going to be something concrete in the next few years. It's great to announce that you're going to support the capitation, but what's going to happen? Tell us exactly what's going to happen, and maybe start with this year, because we're extremely worried about the sustainability of what's currently going on. And not just my wait list as a specialist, but wait lists, for surgeries, et cetera, are only continuing to grow. And I think you can agree outsourcing our work to other provinces is not the solution. So I would love to hear your response in terms of what's coming in the short term to help with upstream solutions.
Great question. You're right, outsourcing is not a long-term solution. It is a temporary solution that we need to do right now just to knock down the capacity. We're trying to balance out, Minister Hindley and I, we're trying to balance out on our surgical side of things, how we can maximize all of the surgeons that are out there and our backlog without burning everybody out. And that's what we don't want to do, is we don't want to create another problem where we've got more doctors retiring. As far as us announcing the blended capitation, it's a very valid point, because governments have a tendency of announcing things and then it sits there for a while and sits there for a while. So what we talked to the board last night, or yesterday afternoon, and again with the executive last night, is we want to move on this very quickly. And that is, in my mind, that we would have something stood up and in front of you, I would say within the next 12 months, that it is there and it is in front of you. So if sooner, we will do it sooner. But I don't want to put the expectations out, because this is a large project to switch over. As was identified, we haven't changed any of our payment to physicians since the 60s when the fee-for-service came in. We want to do it right. We want to do it in a timely manner, and we want to make sure that the reason we're announcing it today is we want to send the signal out to the physicians is we are supportive of this, we are going to do it, and we're going to do it quickly because we see what's happening in other provinces, and we want to put our best foot forward, not just on the dollars, but the working conditions, the team that will build around the physicians. So we want to be able to do all that, but I want it done in a proper way. We've looked at other provinces. We're going to be gleaning what other provinces have done, pick the best stuff out of that, sit down with the SMA executive and say, okay, this is where we think we need to be. Where is it that you're hearing we need to be? And negotiate that very quickly because, and I'll just put it in a different context, Minister Hindley and I have a budget to prepare. I mean, we haven't finished voting off our current budget. We have a budget to prepare for next year, which starts in July. And if we're going to earmark dollars for this, we've got to put all of those buckets of money out there. We have to start figuring this out. So the idea would be to move on this extremely quickly, certainly within this fiscal year, and prepare for next fiscal year. So we're not just going to announce it and let it sit. We're going to move on it.
Can I come back to microphone 1, please?
Thank you, ministers. Ebenezer Adedigi is my name, family physician. I represent the Southeast area. Other speakers took 2 of my points already, though I will come back to touch on them. One point I want to address is mental health access in Southeast area. Last year I was at the RA and you mentioned the dollar amount that is going to be invested in mental health. I need to tell you, we've not seen that translate to what we do, what we experience in the rural, whether for physician recruitment, retention, counselors, psychologists. It's not translating to what we see and what we experience. Our patients are having difficulty with mental health care, mental health access in the rurals. We need you to please do something different and more concrete. Lastly, quickly, I want to say for the incentive for the rural qualified rural sites, can you please, or will you please review the fact that physicians that have been working before 2018, which is your base year, are actually included, because what you are telling them is, you know what, we don't care about you. It's been very divisive among my members, and they are not happy about it. Please review and involve every physician in the qualified org to please be involved on that program. Lastly, I want to say, please, we don't throw money at healthcare system to solve it, and you don't wait until election year to solve healthcare problem. Please do something urgently about the primary healthcare capitation. Thank you.
Thanks, Doctor. I'll maybe work in reverse there. Thanks for the comments and the advice. Just on the Rural Physician Incentive Program, we've heard that this program has been around for some time in a couple of different iterations here, and it's never easy making a decision as to how much it should be, how many years it should be spread over, who's it targeted to, who's eligible, who isn't, and that always makes for difficult decisions for us as policymakers when we're trying to make the best decisions that we possibly can to make sure that we have the most effective program that we can. And just please know that that's not the intention. We greatly value each and every one of you, regardless of whether you're new to the healthcare system or if you've been there for years or decades supporting healthcare. So, but appreciate your comments on that with respect to the program, and we can take that back. Just on the mental health piece, and we've been working very hard over the past number of years to build capacity, not just in the area of mental health and addictions, but in healthcare in general, building year after year to try to build up that capacity in the healthcare system, address not only the short-term challenges that we face, but also get at some of the medium and longer-term challenges we have as well, which is, just as an example, is why back in earlier this past winter, Minister Merriman and myself and the Minister of Advanced Education announced a substantial investment into more post-secondary training seats, into a bunch of other different healthcare designations. That's not going to get us immediate solutions, of course, but that's years down the road. But that's the type of prep work we need to do. Minister Merriman and I were meeting with, just last Friday, we were here in Saskatoon meeting with the deans of the health sciences at the University of Saskatchewan to talk about some of those other ideas as well. For future decisions for us as a government. But just on the mental health and addictions piece, and specific to Southeast Saskatchewan, we'll take a closer look at what we have there. What do we currently have? What are we short? And what do we, in terms of healthcare professionals? Because you're right, we need to be able to make sure that you're fully supported, that we have the right healthcare professionals in the right place at the right time, providing that healthcare to those patients access when they need it. And that means we know we have pressures in that area of mental health and addictions when it comes to having the appropriate professionals there, psychiatrists, psychologists, mental health counselors, you name it. And we're trying to build capacity as quickly as we can. We'll take a closer look at what we're doing in Southeast Saskatchewan and follow up with you to see how we can help build and address some of those challenges there. So thank you for raising it with me directly.
I'm going to come to microphone 2, and then after that we're going to go to the guest microphone. If you would prepare yourself at the guest microphone and make your question very concise for us, please. Microphone 2.
Hello, my name's Kirsty Sanderson. I'm a delegate and also I was a member of the Primary Care Compensation Working Group. First of all, I'd just like to thank the Minister for his announcement. It sort of took the wind out of my sails initially. But I want to address a couple of comments the last two colleagues brought forward as well. As we've already said, the blended capitation model is not something that we can invent or develop overnight. I still want to say that, you know, family medicine and family physicians are in crisis and burnout. And we absolutely need some timelines on some transitional pathways that will sort of lead us forward, and I hopefully will help retain physicians for that little bit longer, waiting for the improvements. We absolutely cannot wait. COVID showed that we can develop sort of virtual care codes and interim payment models virtually overnight. I mean, we virtually did. We were paying people monthly, and virtual codes came in very quickly. So it is doable, it is possible. I would just ask if you could give us some idea on some timelines, maybe on the transitional pathways that will help us get there, because we absolutely need them this year. I mean, we just can't wait.
Yeah, and thanks for the blended capitation. We started talking about this last summer to the fall was when the SMA started to bring this forward. And just in timeline perspective, Minister Hindley and I have been in our positions for just about 2.5 years. The first 2 years were pretty consumed with what was going on with COVID, and we started to just come out of that. Not that COVID is over, and I want to be very clear about that, but that we started to be able to focus on forward versus reacting to everything that was happening with COVID around the world and vaccines and all of the other stuff that everybody in this room is very familiar with. We finally got that opportunity to start looking forward on what we were doing. The SMA, Bonnie and Dr. Jeffrey approached us with this model. BC came out with the model, I believe, just last fall. So from our perspective, we're moving on this very quickly. And we want to be able to move, and we have unanimous support from our government on this, from our officials. We want to move on this quickly. That's why we've tried to put a couple of other incentives out there. Minister Hindley talked about the $200,000. We've talked about the extension of the urgent care hours, the other fee for service. We're not going to stop everything right now until that model comes. We're still working on a bunch of things in behind the scenes to be able to help out in situations where you are. We've got a good, robust class in the U of S, which again doesn't solve your problem today. But I also want the room to be conscious of this, is we're probably 6 to 9 months ahead of other provinces as far as our recruitment of not just physicians, but nurses, other technicians. We've recruited in our province 170 physicians in the last 19 months, 70 of them have been family doctors. So we are recruiting, we are doing all that. We're trying to take the pressure off. We've introduced physician assistants. We're looking at expansion of scope of other. So we're trying to maximize everything that we have. In saying that, I understand you're still seeing a lineup. and that's real. And what we're trying to do is bring as many people in as we can and many programs as we can to be able to take the pressure off of you so you're not overwhelmed and you can continue practicing and making sure that your patients are getting the best health care.
Thank you. Can I thank you for your patience on microphone 3, and go ahead. Okay, while we fix that, we're going to go to microphone 1, please.
I feel bad, you should use this one. So my name is Sarah Miller. I'm section chair of general surgery. I practice in Regina and have a fairly large component of breast cancer care in my practice. You might be aware of the CIHI report showing pretty terrible timeframes from diagnosis to surgery. One area that I'm finding is quite difficult is getting timely access to diagnostic imaging for these patients, most notably MRI. Often we have women with biopsy-proven breast cancer that are waiting 4 to 6 weeks for MRI, where they've already waited 6 to 8 weeks for a biopsy, and just this time frame keeps increasing and increasing. I'm just wondering if the government has any suggestions or any action plans for this, because I think we're failing women in this province.
And I've heard that concern, a few on access. Similar to our surgical backlog, there is a backlog on our scans as well. And we are trying to prioritize those ones. We have bought more capacity both in Saskatoon and I believe in Regina as well to increase the amount. We have lots of philanthropists coming looking at whether we're going to expand. I think that there's an opportunity in Regina over at the Pasco that we are looking at specifically to see if we can expand capacity. Again, that doesn't solve your problem here and today, but we're building capacity for the future. We certainly want to make sure that women are getting the treatment that they need to be able to get between the biopsy and the scan, and then ultimately surgery and treatment and recovery, and make that time as short as possible. But I'll see if we can connect right back with you, and if there's something specific that we can do, if it's expansion of hours, if it's more techs, we can certainly have a look at that.
Let's try that third microphone again. If it's not working, we'll scoot you over to mic 2. Okay, let's move you over to mic 2, please. Yep, go ahead, please.
Hi, thank you. My name is Elke Hutton. I'm with the CMA Patient Voice and the SHA as a patient family partner, but I am here on my own volition. Nobody's telling me what to say. I just wanted to thank you for the ministers for being here today, and for all the SMA physicians who are doing such a great job supporting their patients through this pandemic. My question is this. For so many years now, patients have been caught in the crossfire of disagreements between physicians, other healthcare professionals, and their organizations, and the Ministry of Health. Because of these ongoing disagreements, access and quality of care worsened significantly, and our healthcare system is no longer working as it should. We need now new patient-centric policies within the current healthcare system. My question is this: do we have the Ministry of Health's commitment to co-create policies towards a new and better system based on full transparency, honesty, and accountability with all stakeholders, including patients as equal partners involved in all healthcare systems operations?
Maybe I'll start with that one. This is exactly what we're trying to do with our new physician-led primary care team, to make sure that we are looking at the patient in a holistic approach. And as was identified yesterday at one of the board meetings is, from one of the physicians there was, they need experts in each one of their areas to be helping out their patients. And we are absolutely looking at that. We're trying to wrap everything around the patient as much as we possibly can in each specific discipline for their care. And I just, this is something where as a parent and as, having siblings and family members, we want the best patient care for our family members too. These are our neighbors and our friends and that. So we do want to have that continuous care, but we want to make sure that they're getting the best care. And what we're also trying to do is make sure that everybody is operating at the top end of their scope. We don't need a physician doing something that an RN or an LPN can be doing. We need them operating at the top end of their scope, so they're maximizing their time and their knowledge and their experience. So absolutely, we're committed to making sure that the patient is in the middle of the primary care team led by the physicians.
I'm going to stay at microphone 2, but before we go back to the question at microphone 2, I want to check with the ministers. We had a little bit of a late start. I know we're maybe running into your schedule. Can you give us another 10 minutes?
Sure, and I just got some additional information on the scans for Regina, and I'm not sure where that physician, there. We did invest an additional $7 million for CT and MRI scans in the system this year, so that's on top of what was there last year. So hopefully that will be able to alleviate some of the capacity issues and some of the backlog that you're seeing from from lab tests to biopsies to treatment.
Thank you. That was the easiest 10-minute negotiation I ever did. I was willing to go as low as 7, but I love a minister who's going to give away the store, don't get me wrong. So, microphone 2, please.
Hi, I'm Brent Toma. I'm an emergency and trauma physician in Saskatoon and the representative to the RA for the emergency medicine section. So I'll start with my question and then provide a bit of background and context. So my question is, what is the plan that we have, specifically the urgent near-term plan, to address the access block crisis in our tertiary care emergency departments? So I can tell you, I've just lived in the hospital for last week on trauma call, there every day, all day, and many nights, and I've seen the ebbs and flows of our emergency department in addition to working there. Almost every Monday, it's a bit of a train wreck. To give you an example of what it looked like this Monday, our UH emergency department has 35 beds. We have 20 overflow beds in the old emergency department that we're staffing. On Monday, we had 58 admitted and consulted patients in the emergency department because there was nowhere else for them to go in the hospital system. So by my count, we had -3 beds to see all arriving emergency department patients. That's rough. Like, I don't know if I can express how I can express that, but like what that means on our work environment on a daily basis is that patients that are CTAS 2, like high acuity patients that need immediate monitoring, those patients are frequently in the waiting room, unassessed and unmonitored. Those patients are frequently in the hallway. I know you've seen our back hallways, and we've done a good job of trying to accommodate those paramedics, but those paramedics are off the street, frequently staffing our emergency department because we have no room for them, and we are frequently hitting times where there are 0 ambulances available in Saskatchewan, or sorry, in Saskatoon, because we're all having them all in our department. In terms of what that looks like for working in the emergency department, that means we don't have any capacity from all of our allied health people to support our patients. So
Can you finish your question?
Sorry. Yeah, I spend my time changing bed sheets and doing all of those things.
We'll get an answer from the ministers.
My question was stated at the start. Thank you.
Thanks very much for your question. And what Minister Hindley and I have been doing is talking to staff throughout the system, right from the ambulance, the EMT, the advanced care paramedics, to the ER doctors. It's a flow issue. It's a flow, from what I've been explained, of people coming in, being seen, going up to the upper floors within the hospital or surgery. We did have a issue of ambulances, transportations coming in from outside of Saskatoon and Regina and being admitted through the ER and getting their labs done there. We're working on bypassing that so they can go directly up to ward, so we're not plugging that up. The overall flow is an issue. It's a matter of when patients are being discharged, what their discharge protocol is, where they're going for surgery. We have been able to make some strides in this. Now, in saying that, there's a lot more we need to do because you are coming into full beds in the ER. I've talked to nurses and that. What we've been able to do is reduce, and it has reduced, it's been creeping back up a little bit with the EMS coming in and dropping off patients. We had a 40% reduction. It's kind of creeping up there again, but we need to get that down where they can turn around and get back out with their ambulance and be able to serve individuals. The other one is the admit no beds, the alternate level of care that are in the hospital. We need to move them on to more permanent solution. They can't be in that hospital for an extended period of time, and Minister Henley's working on that with long-term care. So it is an overall flow issue, and unfortunately, it gets plugged in the ER. That's where everything stops, because you can't not take patients in, especially if they're at a CTAS 2. So we have been able to reduce the overall stay in hospitals across the system by 1 day. Now, 1 day doesn't seem like a lot, but when you're doing all patients, that is. And that was within about 6 to 9 months. We're continuing to keep our foot on the gas on that so we can reduce the amount of stay that people are in there, give them the care that they need at home, not just kick them out of the hospital, provide them with the care at home, but make sure the flow through the hospital is working, because the problem is it gets jammed up. I look at the Saskatoon website all the time to see where it is as far as no beds, what the ER is looking at, and it's full. And it's a flow throughout the whole system to be able to do that, and we're working with each department head to make sure that the flow is better, maintaining patient safety.
One, please.
My name is Kirsten Jewett. I'm a member of the Representative Assembly for Saskatoon. I am an urban family physician practicing in Saskatoon and just doing solely family medicine. I have 2 quick questions, don't worry. The first one is for Minister Hindley. I am one of 5 physicians who participate in the psychiatry family medicine partnership to see some mental health patients. It is financially disadvantageous for me to do so, and this might be why there's only a few of us. The question is there something to compensate us for this additional workload? The answers would be yes, no, or now it's on my radar. And for Minister Merriman, I'm finishing my 2nd year of practice. I'm a Saskatchewan native. I want to stay here. I'm going to stay in Saskatoon. But so I am that person that you want to retain. My contract is up at the end of August. I will not be retaining or staying in that role unless there is something concrete for me between now and August. What do you have on the plan? I see $200,000 for rural family physicians. What is for us in urban?
Great, thanks, Dr. Jewett. I'll start with the question on psychiatry, and I'd like to actually come chat with you afterwards just about, because that is one of the bigger pressures we face right now. No surprise there when it comes to psychiatry in this province, and this is part of the conversation that we've been having with our officials and with the SHA about, how is it, what are the barriers, what are the gaps towards retaining and recruiting psychiatry training here in our province. So I'd like to have just further that conversation with you in terms of ideas around that, because what we're doing is no longer working as well as it should be when it comes to recruitment and retention in this very important field, which is only going to be growing and has been growing over the past number of years when we're talking about mental health pressures, addictions, and that whole scope of just everything in that field. So be very much grateful to follow up with you and just have a conversation about some of your ideas as to what we can do to help make this better for you in that area. Paul, maybe let you answer that question.
Yeah, sure. And I'm really hopeful that you will choose to stay. What we've done with our package is we've put that and focus, because again, we get a finite amount of dollars from the Treasury Board process that we go to, and we have to allocate that out. What we focus that $200,000 for rural and northern communities that don't have a doctor or have not had a doctor. This is the ones that we chronically can't recruit into those areas, so we have to throw some dollars at that. Now, there are still challenges in the city, absolutely. For us to be looking at that, it would be something that we would have to sit down and discuss with the SMA. I think one of the biggest strides we've been able to move forward is adjust some of our fees. This new model that is coming forward on blended capitation is something that the doctors have been calling for, that I've been hearing from them calling for, that would properly compensate them for what they are doing. So we're trying to do as much as we can on the retention side to make sure that we're keeping physicians here, because we don't want them to just turn around and out the door. We want to keep them here as long as we can. I know your contract's up in August. I would certainly hope that you choose to stay, but understand you got to do what's best for you. If there's another province that is looking at incentives that, that we need to be looking at, I'd invite you to float that up through the SMA, and we'll start to have a discussion about it.
Out of consideration of the minister's time and the next presenter's time, this will be the last question from microphone 2, please.
Welcome to the ministers, and thank you for coming today. We appreciate you working with the Primary Care Compensation Working Group. I heard you state
Yourself, even though you
sorry.
are the past president.
Barb Konstantinovich, family doctor, Regina. Born in Saskatchewan, raised in Saskatchewan, trained in Saskatchewan, and worked throughout Saskatchewan. I heard you state that it would take about a year. We, as a previous colleague stated, virtual care came up in 2 months. British Columbia came up with their plan in 6 months. As a colleague that was just previously at the microphone said, I might be done in August. We can't wait a year, Minister. We can't. And I know that this government has strength and power and capacity and skills, and we're putting our trust in you to move this a whole lot faster. And I know I've spoken to you directly about this. I said October is even too late. Please, ministers, take this back to your colleagues and let them know how serious this problem is and how much we want to stay and make Saskatchewan the best place. My ER colleague earlier spoke about how he's swamped. Imagine if there were family physicians in community that were supported to look after those patients before they ended up in the ER. The lovely lady from the Observer microphone said, what about us, the patients? Well, we're asking, please, before October.
Thanks very much for that. And I can't preempt, I want to have it done as soon as possible, believe me. I do, for multiple reasons. To strengthen the industry, or strengthen all of the professions out there, to let everybody know that this is extremely important to our government. This is. As I've said, governments traditionally don't move very fast on these things. We are moving, in my opinion, very fast, but we're also creating a new model, and we haven't had a different model in 60 years. This is a negotiation between us and the SMA. So there's two parties at the table that will be discussing this. If you're asking me to put a proposal forward and the SMA just accept it point blank, they might not agree with that. So we do have to go back and forth. This is a discussion, and that's why Bonnie and her team and Dr. Epp taking over as new and the SMA team, we have to negotiate this out, just like we do with everything else. That we're committed to making that go as fast as possible from our perspective. We have to look at the fiscal responsibility of it, and we also want to make sure it's done properly. So we will move it along as fast as we can, and I did hear you last time, and we'll continue to move it along as fast as we possibly can. Yesterday I made a joke with one of our guys that's the lead on this and said, enjoy your summer vacation, you just had it. So we want to work very quickly on this, believe me, we do.
I am going to offer some thanks, but before I do that, I want to tell you, I'm going to step off the stage to allow everyone to get by me. This session is not over. Remain in your seats. I feel like the substitute teacher saying, I'm going down to the principal's office, be on your best behavior. Thank you to everybody who asked a question. Very many apologies to people who didn't get a chance to ask. The number of people interested is a reflection of our appreciation for the ministers being here today. And thank you so much to the ministers for taking time out of your busy schedules to join us today. Thank you.